Right, where?
Okay. Who offer? Who offer?
Check.
Okay. Prof. Sonia, are you with us? Sonia, are you with us? Belum, tapi dia belum. Halo Sonia, good morning. Oh dia baru. Hello Sonia, good morning. Good morning, how are you?
Good morning. Just for a moment, I'll turn my volume up. Yes, I'm just trying to get the light right.
There is also Ofa here.
Sorry?
You met Ofa
Yes.
2 weeks ago.
Hello, good
Yes.
morning.
Good morning.
Good morning, Sonia.
Good morning.
How are you?
I'm good, thank you. It was cold and foggy here this morning.
Oh, really?
Oh, God, yes,
What
yes.
time is it now?
Nearly 11 o'clock. So you were all bright and early.
Yes.
Ofa, are you okay?
Yes, I'm fine.
Because you using color, neck color.
Yeah.
Yes,
What
have you done?
To make my neck straight.
As long as you are all right over.
Yes, I'm fine. Thank you.
Okay, we will begin in 7 minutes. Okay.
Lucinta, do you have the slide or whatever from Sonia? And
No, I have the slides. Now, how come my back thing is back to front? It says, isn't that back to front?
Yes. That's
It's
fine.
fine.
The
It's
virtual
fine.
background is fine.
It's fine because when I am looking at it, it is a mirror.
No,
Like it is not, it is reading that back the wrong way. No, it looks
no,
all right.
no. All right. Yes.
Um,
We can co-host as a co-host, so Professor Sonia can share the slide, the presenter.
I can
Oh.
just let me.
Just check.
Yes.
Okay. Yeah, perfect.
No, let me just make it into the slideshow because it's not slideshow.
Yeah.
It should be, yes, now it will be right. Oh, no, hang on.
No, yeah, you are not click the slideshow yet.
Okay.
There.
Yeah, perfect.
Okay, perfect. Sonia, we will start in 5 minutes because the MC should open the lecture first.
That's okay. That's fine.
Okay.
So do you want me? I'll take my share screen away.
No, it's okay. It's okay.
So the only thing I have just realized because I am at the hospital is I hope there are no code blues or Met calls or
Yeah, hopefully. We are also in hospital.
so it could happen at your end too. Okay.
Yeah. And our COVID case is increasing right now. So yeah, we have to take our masks.
Yeah, I am supposed to be wearing my mask inside here at the moment as well. So please do not tell on me.
Okay, Dr. Ratri, you may start the lecture to open the lecture, Dr. Ratri.
Okay, thank you. Yes, I would like to start the meeting right now. Good morning,
Please.
Professor. Good morning, Professor, doctors, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. Peace be upon you. Her Excellency, the Dean of Faculty of Medicine, Public Health and Nursing, and also the Head of Social Obstetric and Gynecology Division, Universitas Gadjah Mada. Honorable, the Head of Department of Obstetric and Gynecology, Universitas Gadjah Mada. Respectable, the Chairman of this event, Dr. Sinta Prawitasari, Consultant of Social Obstetric and Gynecology. Honorable guest, Professor Sonia Grover, MBBS Franzok MD, and all the respectable participants of this event. First of all, we would like to welcome you and thank you for virtually joining the guest lecture. What's so special about pediatric and adolescent gynecology? Please let me introduce myself. I am Ratri Wulandari, Master Ceremony of this event. Before we start, I would recommend participants to mute your microphone in order to minimize distraction during the meeting. Thank you. So, ladies and gentlemen, of Department of Kusuman.
I'm sorry, you have frozen and I'm not sure if you wished me to start. I have lost.
No. Okay, Sonia, you haven't started your lecture yet. We have to open the lecture
Okay.
with
Okay.
the head of the department and also Prof. Ova. Okay.
Okay.
I will let you know.
Okay.
Yes, apologize about the disruption.
Oke, HP saya, Pak.
Dear audience, professor, doctors, ladies and gentlemen, we would like to open this event by an opening remarks from the head of Department of Obstetric and Gynecology, Universitas Gadjah Mada, Dr. Ardanu Kusumanto, Consultant of Gynecology Oncology. Please, Dr. Ardanu, the time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Dear colleagues in the room and those who are virtually connected, I am pleased to welcome you to our this morning guest lecture about what's so special about pediatric and adolescent gynecology, which is organized by Social OBGYN Consultant Training Program of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. We all understand the importance of our topic today, pediatrics and adolescent gynecology. On behalf of the Department of Obstetrics and Gynecology, FKK-MK UGM, I welcome and also thank to Professor Sonia Grover, MBBS, Friendship Medical Doctor, as our distinguished speaker this morning, and Dr. Sinta Prawitasari, OBGYN consultant, as our moderator this morning, and also our beloved Dean, Professor Dr. Ova Emilia, Master of Medical Education, OBGYN consultant, PhD. I am very grateful for your presence to share new insights on this issue so that it will be very useful for our daily practice. I would also like to thank to the attendees this morning as well as the committee for organizing such a great event. I am confident that we all will find new ideas about this issue, fresh energy to start improving our services in the field of female reproductive health. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Ardanu. The next agenda is a speech from the head of Social Obstetric and Gynecology Division, Universitas Gadjah Mada, Professor Dr. Ova Emilia M.Ed, PhD, Consultant of Social Obstetric and Gynecology. Please, Prof. Ova, the stage is yours.
Thank you, Dr. Ratri. Can you hear me clearly? Yes.
Yes.
Okay.
Yes, it's pretty clear.
Distinguished speaker, Professor Sonia Grover from the University of Melbourne, and the organizing committee, Dr. Sinta, and all colleagues, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh. Very good morning. Yes, today we are very fortunate to have an important guest lecture from the first-hand expert who know the information, knowledge, the competence, and also experience in the area of pediatric and adolescent gynecology. We have to acknowledge that the topic is very, very important, and yet, if I may say, is being neglected. It is not much discussed about this topic. So when you look at the pediatric or adolescent patient, sometimes we think that they are the miniature of adult patient, which I think it is not right. Yeah, there must be different in approach in management, and it should be multidisciplinary approach. So when we look at this, that we have to reflect to our own competencies and also experience about this. I think it is a good start to have the guest lectures with this topic and the area that we really have to learn. And also, when we look at our demographic bonus that we have for young populations, that in the near 10 years ahead, we have around 40% are young populations. So the competence is even more important. So I think this is the start for us to learn more. And we hope that we are going to have more collaboration, more perhaps lecture, discussion, or seminar for the enhancement of the area. Again, thank you again to Professor Sonia Grover to spare the time for all of us to share your knowledge and also experience for today. And also thank you to the organizing committee for all the efforts for creating this event. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof. Ova. We will then proceed to the main session of this event, which will be led by Dr. Sita Pravitasari, Consultant of Social Obstetric and Gynecology. Please allow me to introduce Dr. Sinta. She is a consultant and also a lecturer in Department of Obstetric and Gynecology, Universitas Gadjah Mada. Dr. Sinta just finished her doctoral study in the effect of crew resource management teams, step 2.0 in the quality of obstetric care in teaching hospital. She has interest in social obstetric and gynecology, such as cervical cancer screening and family planning. Without further ado, please, Dr. Sinta, the stage is yours.
Okay, thank you very much, Dr. Ratri. Good morning, Sonia. How are you today? Okay. It's an honor for me to become the moderator for your lecture. And before we start the lecture, I will read your CV, your brief CV first. Okay. The Professor Sonia Grover was a gynecologist, Director of Department Pediatric and Adolescent Gynecology, the Royal Children's Hospital, and also a research fellow of Murdoch Children Research Institute. Also, she has been a member of Executive Committee. Now she's current President of Executive Committee, International Federation of Pediatric and Adolescent Gynecology, and also executive member of Australian New Zealand Society of Pediatric and Adolescent Gynecology. She has already written a lot of journal articles, and the last article was the missing uterus, the missing diagnosis, and the missing care, Mayer-Rokitansky Kushner-Hauser syndrome in the lives of women in Malaysia. She's been doing collaboration also in Asia Pacific area and including Malaysia. Please present your lecture and please, Dr. Prof. Sonia, the time is yours.
Good morning, everyone, and thank you very, very much for your very kind invitation to speak to you today. And it is a great pleasure for me to increase my links and friendships and develop close collegial work with other places in our region. And I hope that this is the first of many opportunities when we will be able to talk, and I hope one day meet face to face so that we can continue to share our interest in giving the best possible care we can give to young women. Let me just share my screen now with you. Just let me see if it. So what I'm going to talk to you about today, I'm not sure if I missed that. Yes, what is so special about pediatric and adolescent gynecology? Why do we need to think about this as a separate area of gynecology? Because if we think about this, you're going to tell me, but you know, our pediatric colleagues are looking after these young women and the pediatric surgeons are doing this. And anyway, we are gynecologists, we can just simply look after the younger version of adult women that we've all trained with. Well, if we stop and think about our other colleagues who do provide care to young patients, the paediatricians aren't necessarily very comfortable or knowledgeable about talking about periods or sexuality or fertility. And they don't necessarily feel very comfortable examining female genitals. So although we make a presumption that our paediatric colleagues and our paediatric surgical colleagues can do all of this area and don't need us, I think you'll discover when you think a bit harder that maybe they don't. So let me just walk through that a little bit more clearly. So, and let's stop and think about us as adult gynecologists. Now, as adult gynecologists, what do you know about rhabdomyosarcomas in childhood? Do you think that we as adult gynecologists know much about it, or on the other hand, that we have anything to offer to the care of these young girls? And I can certainly think of, when I think of a rhabdomyosarcoma where the paediatric surgeons were involved, and it was a rhabdomyosarcoma involving a cervix, and surgery was being considered, they were just going to take out the uterus. And it wasn't until I said, well, do you know that adult gynecologists will actually do a trachelectomy and remove a cervix and conserve a uterus in an endeavour to save a uterus. And so the paediatric surgical colleagues had no idea about that as a possibility. So you do have something to contribute in that setting. And what do you know about anatomy and the Mullerian tract as an adult gynecologist? What do you know about what the anatomy is like in a young girl who's got bladder exstrophy? And what might we as paediatric adolescent gynecologists be able to contribute to her care? Do you understand what happens with the anatomy in somebody who's had a cloacal exstrophy or a cloacal anomaly? Do you know what to expect about where the uterus might be or what the vaginal issues might be in somebody who's had this anomaly? As an adult gynecologist, you'll have had minimal exposure to this. And what do you know about what the anatomy is like in a girl who's got congenital adrenal hyperplasia, who's had a urogenital sinus? Do you, as an adult gynecologist, have any experience, any exposure to how to correct any of that anomaly or be involved in the care of that sort of anomaly? Maybe you've had experience in dealing with obstructed septums in conditions like uterine didelphys, because relatively they're a bit more common, but not everyone has seen that or is comfortable with knowing how to deal with that. And you as an adult gynecologist, how do you feel about caring for those younger patients? What are your skills like in interacting with 3-year-olds? As an obs and gynae person, you're dealing with 30-year-olds, you're dealing with pregnant women. How do you interact with the 3-year-old? And how do you go interacting with the teenager where you've got a mum in the room and a teenager in the room, and you've got tension between the two of them, you've got parents who are fussing over teenagers who are trying to grow up, you've got teenagers who are too busy on the phone. What are your skills like with engaging with them? Because in fact, they are the ones who need contraception, possibly. They are the ones who have a problem. Are you talking to the mother or are you talking to the young woman? So as a gynecologist, we've had very little training in interacting with those age groups, unless you've had the opportunity to explore the field of pediatric and adolescent gynecology. What are some of the differences when we think about this younger population? Well, clearly the teenagers are going through a phase of their life where they're often doing risky things that are affecting their behaviour. They're tossing, they're trying themselves out as more independent, growing up, trying to separate from parents, but on the other hand, still quite dependent. And so it's a challenging time for the young person, and it makes a challenging time for interacting with them. There is, in fact, different pathology and different findings. So the things you think about with heavy periods in a 30-year-old are in fact very, very different to the things you're thinking about with a teenager. And when we're thinking about correcting a problem, when you're thinking about adult women, you're often thinking about correcting it right now, whereas sometimes there are anomalies in 12 and 13-year-olds that you may be better off delaying the correction of, so that there's a difference in how you tackle a problem. And then there's also the question of thinking hard about fertility preservation in children and adolescents, which our paediatric surgical colleagues may not be as aware of. And even as adult gynecologists, seeing a woman who is 35 or 40 who has an ovarian torsion, taking out the ovary is not such a big issue because she has probably had her children. But what are you doing when you see an ovarian torsion in a 6-year-old or a 15-year-old? So just going back to that phase of adolescence as teenagers and all their growing and changing, there's lots of things happening with where their brains are up to and how they're dealing with that separation and becoming independent. They're also adjusting to their bodies changing, and their breasts are developing and hair under their arms and pubic hair. So there's lots of body changes that they have to adjust to. They're getting a vaginal discharge now that they didn't have before. They're also, as part of growing up, are beginning to spend more time with peers and less time with parents, and then their peers are doing things that they want to participate in. So how do we help them walk that line of not taking too many risky behaviours, but on the other hand, accepting that this is part of growing up? Their pubertal changes, including changing in body features, combined with how their peer group thinks about these things. So peers are now tattooing, piercing, removing hair, and how we accept or respond to that becomes important as well. What are we teaching young people about sex and sexual relationships? And where do they actually get their information? We often make the presumption that families will tell them or parents will tell them. But in fact, that doesn't always happen, because sometimes families, mothers, aren't particularly well informed themselves. And I've certainly, when I've had discussion with colleagues in India, that there are many young women there who are actually having planned marriages before the age of 16, 17, have not yet had a period yet, and they've never talked to their mother about the fact that they haven't got a period yet. And in fact, maybe they've got vaginal agenesis, and the opportunity to have that discussion has never occurred. So we make presumptions that family is a source of information, whereas that communication may not be occurring. There may be ignorance. Are they getting information from friends? How reliable is information from friends? Are there school education programs about sexuality? Are there school education programs about body changes? Are there school education programs about periods? How often are the teenagers in Indonesia missing school because of period problems? Is that acknowledged? Is it accepted? Is it acceptable that women don't miss out? They miss out on several days a month of their school education because they've got shocking periods. Do we ask? Do we know? Or do they get to school and they're really not feeling great, and so they're present, but they're not really present because they're in pain and they can't concentrate? Who do they go to for information about that? And I've already mentioned that there's a lot of pressure on young people to do risky things like drinking, like smoking, with peer group pressure adding to that, as well as all the social media effects now. One of the things when we're talking to teenagers, which we don't do when we're talking to adults, is that we explain that the conversation is confidential. So the teenager will talk to us far more if we actually explain to them that what happens in this conversation with this 14-year-old, this 16-year-old, is a conversation between you and that in fact I get into trouble if I break that confidentiality unless your life is at risk, there are risky things happening to you, or you're about to do something risky to someone else. So there are exceptions, but we know that if we explain that to young people, that helps them to open up and actually say, I have got a boyfriend. And although culturally that may not be what's acceptable, if we don't take on those conversations, then there are repercussions, aren't there? Sorry, I have not looked at what your teenage pregnancy rates are like, but I can be fairly certain that teenage pregnancies are not something that's socially acceptable. But we need to equip teenagers to be able to manage those interactions so that they can avoid things that are going to pose a major problem in their life. When we're thinking about younger females, there is quite different pathology and findings. So, and I would like to walk through some of those differences. So if we think about something as simple as vaginal discharge, if we're talking about a pre-pubertal girl with a vaginal discharge, the most common finding is that this is an atrophic vaginitis. And sure, you can do swabs, but you'll find bowel flora. And so I would rarely do swabs. And I'm going to take simple measures to care for the discharge in this young girl, having made sure that I'm comfortable that she is not a victim of child sexual abuse, and having explored that side of things. Now, clearly by the time we get to a post-pubertal girl, but one who in a confidential conversation it's been clear that she's not sexually active, because remember that if you ask that question in front of a parent, then no teenager is ever sexually active. But if she's not sexually active, then we have to think about physiological. We have to think about candida, because candida will happen in an estrogenized environment, whereas it never happens in prepubertal girls with no estrogen. And in this age group, we're not going to use vaginal methods of treating, because if they're not sexually active, not a tampon user, then you're not going to ask them to put anything into their vagina. Now, clearly, once they become sexually active, the options of what the germs and the origin of a discharge are going to be quite different. So you can see that depending on age, I'm not going to give Canesten antifungals in the prepubertal girl, and I'm not going to be suggesting, may not even suggest that swabs are necessary, because I don't wish to do anything traumatic. If we think about labial adhesions, in the prepubertal girl, then it's adhesion of atrophic surfaces, which is really incredibly common. And my question always is, have you ever seen an adolescent girl who's got labial adhesions? And unless she's had a female circumcision or FGM done, she will not have labial adhesions. And so the natural history of labial adhesions is actually to spontaneously separate. But if we think about labial adhesions, well, post-childbirth, it could be a traumatic event or traumatic plus atrophic changes while somebody is breastfeeding, or maybe it's associated with other skin conditions such as lichen sclerosis. So you can see that the differential for labial adhesions is relatively different across the age groups. And again, just thinking a little bit more about labial adhesions, our paediatric surgical colleagues have advocated pulling that apart or separating it under an anaesthetic. And my colleagues here in Melbourne used to tell me that pulling it apart with lateral traction was not painful. Well, let me tell you, when I saw those mothers and daughters, when it had re-stuck together again, that they had been traumatised by that approach. And so our paediatric surgical colleagues were taking a very surgical approach and not really considering the psychological impact of potentially doing something painful to the perineal area. The last thing I want is for young girls to feel anxious about their perineums and then feel anxious about having sex with their partner. So what the paediatric surgical people were doing was not necessary, because you and I know that we never see labial adhesions in adolescents, and therefore they were doing a potentially traumatic procedure with no good reason. Paediatricians, on the other hand, have tended to use topical estrogens. But if you use enough topical estrogen, you also get side effects. And once you've told somebody or the mother that this needs to be treated with topical estrogens, then when it relapses and comes back again, which it often does, the parents think it has to be done again. So you can see that both the paediatrician's perspective and approach to labial adhesions and the paediatric surgical approach has been an intervention, both of which are really unnecessary. And it's you and I who are in the position to say, no, 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 adolescent girls, 20-year-old women, we never see them with persistent labial adhesions. The natural history is resolution. What about vaginal bleeding? So clearly the diagnosis in different age groups is substantially different. So in vaginal bleeding for a little girl, although a foreign body is a possibility, we do have to think about things like vaginal rhabdomyosarcomas. Vaginal bleeding in a post-pubertal girl is much more likely to be associated with problems or issues associated with menses. But as we get older, we begin to have to think about cancers, but different sorts of cancers. If we think about lower genital tract tumours, the teaching is clearly very, has always been that rhabdomyosarcomas present with bleeding, but in fact they often present with altered anatomy, with swelling, and not necessarily with bleeding. When we get involved as gynecologists into this oncology area, then we can make the long-term consequences of radiotherapy known to our colleagues, because the paediatric oncologists used to feel reasonably comfortable about, let's just offer radiotherapy, whereas now, because they have me sitting there at the meetings, we're discussing far more the impact of that pelvic irradiation in terms of the uterus and the ovaries. So we had one young woman recently who'd had a pelvic rhabdomyosarcoma, and she was a 10 or 11-year-old. And the radiotherapist, it wasn't uterine, it was vaginal, the radiotherapist made sure that she had a really full bladder before they gave the radiotherapy each time, because that helped to push the uterus out of the way. And he was very proud when he came back about 8 months after her radiotherapy. She had started to menstruate, and he was very pleased that meant that his radiotherapy had not impacted the uterus. But they had not been thinking about that till I, as a gynecologist, was involved in that pediatric oncology radiotherapy field. And I think I have already mentioned that the time when we removed a cervix, and we've done a primary uterus to vaginal anastomosis so that we preserved the uterus. And hopefully, she's still too young, she must be about 11 or 12 years of age now, but she has a uterus. So that gives her the potential for fertility, whereas the pediatric surgical oncology team would have just taken her uterus out. And it was only with my presence there that said, no, wait, let us consider this a little bit more. What about perineal pain? So in little girls, we can see perineal pain as a distressing nighttime, waking up incredibly distressed and often clutching the perineal area, which is not a problem that I've ever seen in women in an older age group. And it took us quite a few years for us to work out that that was lost pinworms, so that they had crawled from the anal rectal area into the vagina and were coming out at night, crawling on that thin atrophic hymen, causing pain and causing the distress. And once a week, treatment for worms, once a week for 3 weeks is going to solve that. Now, the other thing that we never used to recognise was that vestibulodynia or vulvodynia is also a problem in little girls, and the pediatric, the pediatricians are not aware of this condition, whereas you and I, as gynecologists, see this in adult women with a vulval dysesthesia. And using the cotton wool tip, we can clearly demonstrate that we're seeing the same issue in little girls. But as I said, this is not something pediatricians ever think about. And the pediatric urologists, although many of the little girls who have vulvodynia or vestibulodynia or vulval dysesthesia, many of them have urinary symptoms. I have yet to see a pediatric urologist actually diagnose a vulval dysesthesia or a vulvodynia. They respond very nicely to tricyclics, but this is an area where it really doesn't belong with the pediatric surgeons, pediatric urologists, or the pediatricians. So it's an area that you and I as gynecologists, if we're switched on to think about little kids and are seeing them, that we can actually help them. I had one little girl who said to me, you were the 10th doctor I saw before anyone, and you were the first one to fix it. So these girls are often seeing multiple people who are not familiar with these diagnoses, who are suffering, missing school, struggling at school. What about abnormal uterine bleeding? We all know about the Palm-Cohen classification system that exists. And if we think about Palm, with the polyps and the adenomyosis and the leiomyomas and malignancy, in the prepubertal group, we can see usually rhabdomyosarcomas in the very little girls. Very rare to see malignancies such as rhabdomyosarcomas in teenagers. I've probably seen it once or twice. But we basically don't see polyps in the prepubertal. We don't see adenomyosis, and we don't see leiomyomas. In the adolescents, very rare, very uncommon to see any of those structural palm causes for abnormal uterine bleeding. Whereas once you get to the over 25-year-old age group, you begin to see many of these. Now, we do occasionally see adenomyosis now in teenagers, now that we've got improved ultrasound capacity with some of our clever gynecology scanners. And there's one other condition that belongs in here, which is the cystic adenomyomas. I'm sorry, I put the stars in the wrong spot. They belonged over here. So, which I'll come back to in a moment. If we stick to thinking about Palm-Cohen, that FIGO classification, then in fact, coagulopathies are definitely an issue with teenagers. And we, in our in some of the work we've done here at the Children's, we certainly found that 10% of our teenagers with heavy periods had abnormal bleeding. Although I must say, when we start looking carefully in adults, we will find significant rates in adults as well. But of course, adolescents often present with abnormal uterine bleeding associated with anovulation, so that the immature hypothalamic pituitary ovarian axis can cause that irregular bleeding. And I must say, I get very annoyed at my adult gynecology colleagues when they see a 15-year-old and say, well, she's got pimples, she's got irregular periods, she's got lots of follicles on her ovary, therefore she's got PCOS. Now, teenagers are allowed to have pimples. Teenagers are allowed to have irregular periods because their periods only started 2 years ago or 3 years ago. And now they're stressed at school or stressed with COVID, and their periods are allowed to become irregular again. So please don't use the label PCOS in all of those teenagers. Endometrial causes will certainly, by the time you're seeing teenagers who are sexually active, then you can be seeing endometrial origins for heavy bleeding and abnormal bleeding in the form of chlamydia endometritis. Endometrial causes for abnormal bleeding is still a poorly defined area. Then we've got iatrogenic causes such as use of warfarin, which is obviously relatively uncommon in all age groups. But if we think about heavy menstrual bleeding specifically, then you can see that the list is quite different. You know, adolescence is anovulatory, pregnancy is hopefully infrequent. Submucous fibroids is obviously an issue in older women, and adenomyosis is much more of an issue in older women. So the list is different, and so the investigations you do are significantly different. If we think about period pain, dysmenorrhea, then in adolescence, the primary dysmenorrhea, which is often associated with nausea, with vomiting, with diarrhea, headaches, aches, pains, dizzy, faint, all the symptoms associated with prostaglandins, inflammatory cytokines, all of those inflammasomes that are released as part of the process of endometrial shedding, the biggest cause for that primary dysmenorrhea. Congenital anomalies probably cause only 3 to 5% of the significant dysmenorrhea, but they do need to be thought of, particularly if somebody's got pain that's at the end of a period and pain that's getting worse from one period to the next period to the next period. So a careful ultrasound rather than a laparoscopy, which is where my Australian colleagues would all leap to, a careful ultrasound is often far more helpful. Endometriosis, although there are lots of reports saying that we should be thinking about that with period pain, it's interesting for me to look at the difference in the rates. And I'm not sure what's happening in Indonesia, but certainly in Australia, where there is an element of private health insurance driving some of this, laparoscopies being done for pain and dysmenorrhea are relatively common. At the Children's Hospital, we work hard to address the dysmenorrhea by reducing the heaviness of periods with the use of tranexamic acid. And if girls are still missing school, then we will use hormonal approaches to try and reduce bleeding and reduce pain. And we will run pill packets continuously so that girls are missing their periods. So why is our endometriosis rate so much lower than the rates that others report? The difference is that we would rarely laparoscope women, and we will have used tranexamic acid, the pill, Depo-Provera continuous pill, and only then would we consider a laparoscopy. Whereas others who are using the pill are using it cyclically. And the moment you have a bleed, you are still doing your endometrial shedding, you are still releasing all of those prostaglandins and inflammatory cytokines, so you are still provoking pain. Is there any evidence that removing a few minor spots of endometriosis makes any difference? And the answer is not really. So I find it hard to justify undertaking laparoscopies. Other causes for dysmenorrhea, clearly the things that we think about in older women, such as submucous fibroids, adenomyosis, adhesions and PID are not really on my list at all in adolescents. Particularly if I've done my screening and I know which of my adolescents are sexually active. Clearly those that are sexually active, I do have to think about PID. I mentioned before an unusual thing, which some people call a cystic adenomyosis. That's certainly the Japanese expression for this. Other people are calling it an accessory cavitated uterine malformation. But this is you can see it here on this photograph. You can see there's a lump out the side of the uterus. This lump out the side of the uterus, no tube attached. This is not a rudimentary or a double cavity with a tube attached to it. This is a normal cavity, normal tube, but it's got an accessory cavity which is lined by endometrium. So, as I said, whether you call it like the Japanese, a juvenile cystic JCA, juvenile cystic adenomyosis, or whether you call it a juvenile accessory cavitated uterine mass or malformation, there are a number of different expressions. They're not as uncommon as all that. And these are often better found with an ultrasound than with a laparoscopy, but you need to excise this because bleeding occurs into this cavity and is very painful because there's no outlet. This occurs almost entirely in teenagers. We see the occasional one because it's got such significant pain associated. We do see the occasional ones presenting in women up to their 30s, but the vast majority are young. So this is likely to be a Müllerian anomaly, and they're always on the side wall here. That's why I'm very happy to call it a Müllerian anomaly, because they're somewhere on the lateral wall. I've never seen one in the middle. Tucked under the tube and round ligament is their usual site. Primary amenorrhea, it's very important to appreciate what is normal, when to worry, and when to investigate. We can end up in a territory here where we're talking about relatively uncommon diagnoses. So when we start, on the one hand, thinking about things like, well, if we think about it systematically, we have to first think, has the system turned on? Is this a hypothalamic issue? Is this a pituitary problem? Is this an ovarian problem? Or is it an end organ problem? We know that the mean age of menarche is somewhere around 12, and usually breast development begins 2 years earlier. That means usually at about 10. But mostly young women are going to be menstruating with 4 years of having started their breast development. And it's important to understand what the rest of the family has done in terms of sisters and mother, and asking about fathers and when did his pubertal changes occur. Must say men are not very good at remembering those details. So when we're looking at the young girl who hasn't yet got periods, then the first question is, has she developed her secondary sexual characteristics? Have we actually got pubertal delay? Is this an eating disorder with somebody who's significantly underweight? Is this a nutritional problem? For me, I also have to think about, we've got some very enthusiastic rowers. Some schools have got rowing teams and they exercise so much. So very intensive sport. Gymnasts likewise are often doing very intensive exercise regimes. And I'm not sure whether that might apply in Indonesia, whether those young girls who are doing lots of dancing are actually doing intensive dancing regimes. Have they got an underlying medical condition? Have they got other medical problems that might give you a clue as to what's going on? Have they had recurrent otitis media? Are they short-statured? Is there evidence of thyroid disease? Have they got headaches? Looking for the clues to help direct you in the right direction for a diagnosis for why haven't they gone through puberty yet? On the other hand, if they've started to go through puberty, but they haven't started periods yet, then have they done things in the normal order? Are they actually pregnant? Have they got, if they've gone through, they've developed pubic hair, axillary hair, breast development and they're getting cyclic pain, then you've got your clue to be hunting for an obstructive anomaly. If they haven't got cyclic pain, you might be picking up an obstructive anomaly early, but maybe they're missing an end organ and don't have a uterus and vagina. On the other hand, you're also looking for something that's atypical. They've got breast development, but they actually haven't got any or minimal pubic and axillary hair. Does that mean that they've got androgen insensitivity syndrome? Have they got excess hair? Do you need to be thinking about late onset CAH or other DSDs? And then with all of these diagnoses, how are you going to break the news? Some of these news-breaking things are quite challenging to explain to somebody that they've got XY karyotype. Does that mean you're going to use the words to say, oh, well, you were really meant to be a boy? Or explain to the parents, well, you were really meant to have a son? I have seen that happen. And I must say it takes years to undo the trauma of having used the wrong words to explain to families. Now, this is not a quick consultation. It's never a quick consultation trying to break this sort of news and explain these things to families and to the young person, and walking them through so that they understand that you've got complete AIS, you look like a woman, you feel like a woman, you haven't got a uterus, you can't carry a pregnancy. And I suppose I try and explain that rather than repeatedly using the word testes, I'm actually using the word gonad. But for complete androgen insensitivity, there are in fact testes there, which can stay in situ at least until post-puberty. And then depending on how easy it is to monitor those testes, they are producing testosterone, testosterone's converting to estrogen, and estrogen's making their breasts grow. If you take those testes out, then are you confident this young person will be able to access estrogens and will take their estrogens? So the risk of malignancy with AIS is very, very low. And therefore, I would not be doing anything about taking those testes out in any great hurry. On the other hand, if somebody has gonadal dysgenesis, then I do need to worry, so gonadal dysgenesis and their XY chromosomes, then I do need to worry about a malignancy risk, because that malignancy risk is 30%. So you can see that understanding the different diagnoses and the impact on malignancy risk as well as future fertility is incredibly important. If you've got complete gonadal dysgenesis, used to be called Swyer syndrome. I'm not a great one for using people's names. So XY, 46XY complete gonadal dysgenesis. There's a uterus present. There are streak gonads with a 30% malignancy risk. Those streak gonads need to be removed because they have no fertility potential and they have no hormonal potential. If you compare that to androgen sensitivity, there's actually no fertility potential, but there's hormone potential. So I'm not going to be in a hurry to remove them because the malignancy risk is also very low. I mentioned before the challenge of the diagnosis of PCO in adolescents, and certainly in Australia we have many young women who have an ultrasound done for really no good reason, and there are multiple follicles seen and somebody says this is PCO. From my point of view, that's not a helpful diagnosis. First of all, we know that, and this is looking at 25 to 30-year-olds, we know that 60% of them are going to have lots and lots and lots of follicles present, and that on its own should never be used as a diagnostic criteria. And that a more recent study in human reproduction said that 25 follicles is completely normal, and that we have to accept that irregular menses is completely normal in the first few years post-menarche, that acne is common. No teenager wants any acne, and any acne is too much acne, but in fact, it's common. And so that's not ticking a box for a PCO diagnosis. There's obviously variation in how much hair is present, and we get caught with girls who come from Mediterranean origins with a Greek or Italian background who've got naturally more hair, who feel like they should have the same amount of hair as many of their friends who come from parts of Asia where there isn't much hair. So you can see that there's peer pressure to say hair isn't acceptable. And then there's a question about the results of blood tests and the extent to which we should be using them for any of these diagnoses. From my point of view, if I think about the use of the expression PCOS, the one thing that makes so much difference is weight. And if somebody is significantly overweight, they're going to have irregular periods, they're going to have an increased risk for hirsutism. If I treat the other factors, it makes no real difference to their long-term outcome. But if I use the name PCO, she's going to say that her depression is now due to her PCO because the internet says you get depressed with PCO. But actually, she's being bullied at school because she's overweight. Did you remember to ask the questions about what's happening at school? For me, I've seen young women who've stopped using contraception because they know they're infertile because somebody told them they had PCO. Then they have an unplanned pregnancy. And the one thing that really matters is their weight. And you and I know that if you're carrying excess weight, you increase your risk for cardiovascular disease, increase your pregnancy risk, you increase your diabetes risks. The one thing we need to be focusing on is weight. And I don't need to tell someone to do something about their weight. I don't need a diagnosis of PCO to tell someone, what are you doing about your weight? So I've already said that they don't use contraception, they attribute their mood problems, and they won't try and lose weight because the internet will tell them all of those answers otherwise. What are our paediatric surgical colleagues doing when they see a torsion? Well, our paediatric surgical colleagues, until we educate them, would take this ovary out. Whereas you and I know that if we detort, not that I'm advocating coming back in 48 hours time, but this is a picture 48 hours later. And so you and I know that we can be conservative, but we have to work hard to convince our paediatric surgical colleagues that that's appropriate. Our paediatric surgical colleagues aren't aware of the concept of uterovaginal anastomoses, and therefore, I was actually in Sweden a few years ago, and the paediatric surgical people actually do all the anomaly work, and I certainly caused a bit of upset and distress to the paediatric surgical people when they realised that this uterovaginal anastomosis was possible because I had simply been taking out a uterine horn or two uterine horns, thinking they were going to be of no use at all. Whereas I would start with the presumption that maybe they will be useful and please leave them behind and let's think about anastomosing them sometime in the future. With complex anomalies, quite a number of girls, and certainly the people in the UK reported that, many of them had been told they had no uterus or that they had a rudimentary uterus and were subsequently found to have a functional uterus. So our colleagues' assessment of what's a normal or acceptable uterus can be wrong. Mind you, I've also had my adult gynecology colleagues tell women they've got no uterus, when in fact it's a tiny prepubertal uterus that's had no estrogen exposure, and they didn't realise that where the two round ligaments joined in the middle and it was marginally thicker, that was the uterus with no estrogens in somebody with idiopathic hypothalamic hypogonadism. So adult gynecologists, having not seen inside the pelvises of younger people, are unaware of what the anatomy can look like. I've struggled here to get the pediatric surgeons to make sure that I get asked to the operating theatre, because when they're doing some of their complex cloacal anomalies, I actually like to look at my bits. I hold responsibility for the genital tract bits. And we'd certainly seen a number of girls who'd presented with hematometrus and hematocolpos, because people hadn't realised that there were structures there that were going to be functional, and nobody had ever noted. They were too busy joining bladders and making bowels functional, which is fair enough, but they were missing bits that would become important. We also have a role in thinking about the fertility and what we can do to protect ovarian function in our oncology patients, as well as in our young trans populations. So for most of our oncology patients now here at the Children's Hospital would be having some sort of consultation to discuss future fertility and the impact of chemotherapy on ovarian and testicular function, with efforts being made to see if we can do anything to preserve function. For us, that means that we're doing some ovarian tissue storing. It means for the boys, particularly the post-pubertal boys who are about to get chemotherapy, it may mean storing semen. So it's important that we understand the differences in developmental stage, because how we explain things to a young person is going to be different to how you explain something to a 20 or a 30-year-old. You have to understand where their learning is up to and what they understand about their bodies, and your whole language has to change. And that does take a bit of practice. You have to be aware that there's different pathology, and the tests you do routinely for someone with a problem who was 25 are completely different when they're 5. Being aware of the different anomalies, the anatomy, the embryology is important to help understand, and that's not what we spend a lot of time about when we're being trained in adult obs and gynae. So although we've got colleagues in medicine, we've got colleagues who do lots of adult gynae, they may not know enough about young people or don't actually feel comfortable to provide optimal care. I remember I'd been asked to give some advice to a colleague regarding menstrual management in an intellectually disabled young woman. Now, the intellectually disabled young women can be challenging. My colleague who saw this young woman, even though I'd given him some advice, when he saw the mother and the daughter did what she normally does, which is she wanders around the room, picks things up, turns the tap on, turns the tap off, tries to play on his computer. She's got an intellectual disability. Her behaviour is what it is. And my adult gynecologist said to the mother, take your child away, take your daughter away and bring her back when she's better behaved. That daughter's not likely to ever be better behaved. And in fact, the mother's done exceedingly well to get her behaviour to the standard that it is. She's taken years to get her toilet trained, taken her years to achieve this level. And that attitude of saying, bring her back when she's a bit more grown up and behaves herself, doesn't acknowledge the developmental issues that that young woman faces. And we need to be in the right headspace to be able to acknowledge and recognise the developmental stage of the young person that we're assessing and endeavouring to care for. So I've just tried to give you a sense of some of the issues and where adult care is different to young people care. I haven't talked to you all about the contraceptive needs of teenagers or sex education as very public health and school educational programs, but really tried to focus this from the perspective of obs and gynae training and how that really doesn't fill in the gaps of what you might need to know when you start caring for young people. So thank you very, very much for listening, and I'm happy to answer any questions.
Thank you very much, Professor Sonia Grover. I think it's very, very interesting lecture because it's very new for us, because pediatric and adolescent gynecology is actually a complete different approach in managing those age. Okay, we have a lot of questions for you, and maybe for the first question, we were honored because our senior professor here, Professor Hakimi, is asked you for a question. He said about what additional training, content, and duration is necessary to become an adolescent pediatric gynecologist in Australia.
Look, in Australia, there are a few places now. We probably have an pediatric adolescent gynae clinic now in most states of Australia, and many of those people have worked with me and are now working in different parts of Australia. But if I think back to when I started in this field, I didn't get any formal training, but what I did was I had conversations with, and I was cited in the Children's Hospital, doing only one clinic a fortnight, but I developed close relationships with the pediatric endocrinologist for all the girls with the differences of sex development, and I started having conversations with the developmental pediatricians, the pediatric surgeons, and it took me a long time before the pediatric surgeons believed that I could operate. And then I did an audit of what they'd been doing ovarian. I will admit that I was called in once. Sorry, sometimes I meander, but sometimes stories are helpful. I remember I got called in once at midnight because the pediatric surgeon said on the phone, said, she's got one torted dead ovary and the other ovary looks abnormal. What do you want us to do? And at that point, I wasn't being called for any ovarian cysts. They were all going to the pediatric surgeons. And I said, wait, I'm coming. And that was long enough ago that I didn't detort the ovary. But the other ovary was simply, a mucinous cystadenoma or a serous cystadenoma, and I did an ovarian cystectomy. And so I saved her ovary. And sort of 2 days later, I thought, I wonder what they would have done if I wasn't around. And I actually went back over 10 years of ovarian procedures that had happened at the Children's Hospital. And I discovered they'd done oophorectomies for dermoids, they'd done oophorectomies for a hemorrhagic corpus luteum. And I looked at that as a gynecologist and thought, oh my goodness, a lot of the dermoids that have been taken out, the radiologists were reporting as complex cysts. And I talked to the radiologists and said, don't call them complex cysts. If it's got the appearance of a dermoid, call it a dermoid, or that you think it's a dermoid. And why don't you call a physiological cyst a physiological cyst? And I got the emergency department to start asking menstrual questions because they weren't doing that. And so you can see that I engaged in multiple levels of the hospital, started giving lectures to the paediatricians, and then they started sending patients. And so from a tiny clinic where I was seeing 3 or 4 patients once a fortnight, I now have 4, we do 2 clinics. Anyway, we're seeing 50 patients a week. So my suggestion is if there are people with an interest, you start, a lunchtime discussion group once a month bringing in interesting cases.
Okay.
And see how you can help each other. Even recently, I was talking to the pediatric rheumatologists and saying, do you realise that many of the girls with juvenile rheumatoid arthritis actually get exacerbations on a menstrual cycle basis? And some of them said, yes, I've been aware of that. And I said, well, I can help you. And so slowly people appreciate that there are things that I know as a gynecologist that I can contribute to. Did I answer the question? I'm sorry.
Thank you very much, Professor Crawford.
Yes, thank you. Thank you, Prof. Hakimi. Now we have questions from the residents. The first question is from Dr. Reska. He asks about how do you think the best way for us to make the clinical pathway so cases like these pediatric and adolescent gynecology can be assessed completely and efficiently on the same time. So he asks about what is the how to make the clinical pathway for so cases like this in cases like pediatric and adolescent gynecology can be assessed completely and efficiently at the same time.
For us, we don't run we run a gynecology clinic here at the Children's Hospital, and we are doing a lot of the mental health assessment work ourselves. So we do not do 5-minute consultations. We're actually doing a reasonably comprehensive assessment. And then we work out who else we might need to get involved. But we're actually doing a lot of that ourselves.
Okay, so I think that maybe we could start from now, that if we have patients, pediatric or adolescent cases in gynecology, we should like assess more with approach like adolescent and pediatric gynecology. Yeah, I think we can start now, and hopefully that we can like have case discussion after this in various cases of pediatric and gynecology cases that we have with you. So hopefully we still can have collaborate more because we want to like having like case discussion with you, especially in adolescent and pediatric gynecology cases we have.
I would be delighted to be involved in, if you were to start having some sort of meetings. If you wanted my input, I'd be very, very pleased to be involved. There's no doubt that some of this is challenging and you're raising difficult topics with people, but some of it is you getting braver, and also for people accepting that it is better to talk about these things than pretend they are not happening.
Yes, thank you. We still have more questions for you. I hope you still have time to answer these questions.
I can answer a few more questions, yes.
Okay. From our resident, Dr. Nur Elfi, she asked you about, I'm curious about communication techniques to explore gynecology problem on children. Do we have to ask to her mom or getting information from the kids? As sometimes kids would likely to cover up the information to her mom, particularly on a sensitive case. So what's the technique?
Look, in different contexts and so often when you start asking questions about periods, the mother is much better at remembering when did the period start, how many days, how heavy, so when you're asking those questions, it is often easier to have the mother. But it's worth having a way of being able to ask the young person some questions. And so it depends a little bit on what the problem has been. Sometimes I work in a place where I can take the young person out of the room to weigh them and do their height. And sometimes I will use that as an opportunity to leave the mother behind and just say, is there anything else I need to know? Now, there are other times when it's, I have had a consultation and I can tell by the girl's face, and the mother is sitting a little bit behind, I can see that there are things that she doesn't want me to ask. And so I might make a note for next time to make sure that I have time. Sometimes mothers don't want to leave the room. Sometimes I will take the approach of saying, I'd like to spend some time with your daughter. It's good practice for her to start talking about these things. And I suspect she will talk more to me with you out of the room because you're answering the questions now. But she does need to practice. One day she's going to be a grown-up woman. She needs to be able to answer this. So you can change the conversation and the way you get permission from the mother to spend some time with the young person. But, you know, if you've got somebody with horrible period pain who's also sexually active, then I probably want to end up using the pill to fix her horrible period pain. Whereas if I didn't know she was sexually active, I might try a bit harder with non-steroidals. So that piece of information is incredibly important to get, that she is sexually active. And then I have to convince without disclosing, because if I've got that information that, yes, I've got a boyfriend and I'm sexually active, my mother doesn't know, please don't tell her, then that's confidential information. So when I'm back with the mother, then, you know, I am going to have the conversation to say, look, it does sound like your daughter's really having a horrible time and she's really not concentrating at school and she's suffering a lot. This doesn't sound like a good place for your daughter who's got so much potential to do so well at school. The pill would really be a much better option for controlling her periods. Now, you can tell me I'm telling a fib. I haven't told a fib. I haven't disclosed the information about the sexual activity, but what I'm trying to do is get the best possible outcome for that young woman. And, you know, and sometimes I'll word that in a different way and say, look, I understand the pill's not a great, you know, it's not our first choice, but on the other hand, it's much better your daughter is on the pill than has an unplanned pregnancy. And if you think about that, most parents would agree they would prefer their daughter to not have an unplanned pregnancy. So again, you have to choose that conversation and how you're going to reach that endpoint depending on the family. And I appreciate that there's more cultural overlays for you, but I can struggle I can have some of those same issues here in Australia with my young women and their families.
Okay, thank you. We have a question from our trainee. It's a subspecialty program in our hospital, and she's from endocrinology reproduction subspecialist. He asked she said that the very nice lecture about this adolescent issue, and she wants to ask about teenagers' fertility preservation, like oocyte freezing. Do you have any experience with this case? She asked whether you have experience with oocyte freezing for fertility preservation.
Yeah, look, we don't often do oocyte freezing. We do sometimes, but we're doing ovarian tissue freezing on many of our young patients here now. And we are also doing testicular biopsies for the prepubertal boys. So we are doing a lot. There's a little bit of debate still in that context, and some some differences of opinion in that we are sometimes doing this on girls who appear to have small chances of survival, or so it's a really ethically fraught area at times. And we've had a lengthy debate recently about a girl with Turner's syndrome who's 15, who's got declining ovarian activity. Should we be taking ovarian tissue from her or not? Because what's her risk of cardiac problems anyway? Has she got a bicuspid cardiac aortic valve? Can she carry a pregnancy anyway? So it's a very fraught area, but we're definitely doing it.
Okay, thank you. And this is a question from our other residents. He asks about, he would like to ask about dilemma between performing reconstructive and conservative surgery. For example, septictomy, vaginoplasty, pull-through, or radical surgery, for example, a hysterectomy, to patients with Turner syndrome, uterus didelphys, agenesis vagina, low socioeconomic status, as they do not really consider about the care further maintenance therapy. The family usually asks the doctor just to perform hysterectomy, not conservative surgery. So
yeah. If we're talking about, so clearly somebody with Turner syndrome needs their hormone replacement for all the other reasons. We would probably aim to do something to preserve the uterus. And, if the family is asking for something, my question would be, how old is the girl? And I would be aiming to do something that was menstrually suppressive so that she didn't have an acute problem now, and then she can make the decision herself when she is 18 or 19, so why not stall? Why race in to do something now? And, in another few years, I'm not sure how old she is, why not let her make the decision rather than her parents decide that she should not be allowed to keep her uterus?
So usually we wait for until the girl can make decision by herself.
Yeah, I would endeavour to delay that decision by using continuous HRT, so that sure, she needs her HRT with Turner syndrome. I know that this becomes more complicated for you because you may not have access to IVF, and we also have the dilemmas there about whether Turner syndrome, what's the risk of pregnancy in a woman with Turner syndrome. So you've got multiple levels here in terms of making a decision, but rather than race into a decision that completely takes away an option for her, I personally would endeavour to try and buy some time by running continuous HRT, not let her bleed, not develop a hematocolpos, and therefore a hematometra, and therefore we can allow her to be old enough to be part of that decision making.
Okay. Do you still have time until 9:30?
Yeah.
Because we have several questions more. Okay. Our resident asked you. She said that it's very, very interesting lecture, and he want to ask, is there any technique or method in building communication as gynecologists in approach to pediatric or adolescent? So I think that he wants to know, do we have like a special communication technique for us, because we are not trained well in communicating with children and adolescent patients.
So there is when we think about communicating with teenagers and young teenagers, there is a structure that is known as heads. And heads, H is home. So, who do you live with? Who's at home with you? Because for me, that might uncover somebody who is spending half the week with one parent and the other half of the week with another parent, and one parent's got remarried. So you uncover what the home circumstances are like, and then what are you doing schooling wise? How do you find school? So E for education, employment. Are you doing any part-time work? Do you need to do your part-time work? Is that how you save enough money to be able to eat, do things? A for activities. What things do you do when you're not at school, when you're not at home? What do you like doing? What do you do with your friends? What do your friends like doing? Because that leads into, if your friends are all smoking and drinking, then probably you are too. So, parties, what are your friends doing at parties? Do your friends have boyfriends, girlfriends? Because again, if you've got friends who have got boyfriends, girlfriends, and they're sexually active, then the odds of this young person. So I'm asking questions that are less confronting and gradually walking into the more delicate conversations about drugs and sex. So D is drugs, depression, S, sex and sexuality. Some of that sexuality stuff is, for me, is becoming a bit, almost round the other way, because so many people are now transgendered, want to use the expression they rather than he or she. So, some of that, who do you identify as, is something that has to be asked earlier in my consults now. But S is sex, sexuality, suicide risk. So you can see that starting a simple question like, who's at home with you, is an easy question, and I'm walking into more difficult questions and more confronting, and I'm trying to establish rapport in the meantime so that the young person has confidence to talk, and that I'm obviously listening and engaging with them, trying to build that rapport.
So it's a heads technique.
Yes.
You said before, heads technique.
Heads.
Okay. So I think that we can teach our residents.
Yeah, look,
that.
heads is really, really useful.
Okay, thank you. Prof. Sonia, we have last question from our colleague, from Dr. Henry, OBGYN. He asks you about how about social support, like family or peers, if there are problems on pediatric and adolescent gynecology in Australia. So maybe he asks more about what is the common practice in Australia in adolescent and pediatric and adolescent gynecology.
So yeah, look, the supports that are available, if you have a diagnosis of a difference of sex development, so you've got vaginal agenesis, MRKH, or you've got androgen insensitivity, we actually have a specific worker coordinator here at the Children's Hospital who's really valuable for the family. She knows what all the online links are to the support groups and everything else. So she's really valuable. As a general rule, across services that are available, we don't have anything extra special apart from that person linked to us in for pediatric adolescent gynecology. Access to psychologists, is still not particularly easy. So, and given that here at the Children's, I can be seeing people who are coming from an hour away, it would be crazy if I was making them see a psychologist here. So I refer them back to their local doctor to try and see if their local doctor can find a local psychologist. Likewise, dietitians, we're trying to find dietitians that are local. We're trying to find physiotherapists who are local. So it's not as if there's a whole network of specific supports in this area. Social work, is available in the hospital. There is some social work support for people who are the Indigenous people, so we might be able to access a bit more that way. But it's not as if social supports are brilliantly available for families in need. I can be looking after people who are, I would say, couch surfing. So I've recently had a young woman who had a uterine anomaly, and she's been sleeping on the couches of various friends over the last month or so. So I haven't got a quick fix to solve her social problems.
Yeah. Yes. Thank you very much. I think that's the last questions. Thank you very much for your valuable information for us about our introduction. This is only introduction about pediatric and adolescent gynecology. Hopefully that we can collaborate with you in we would like you to join us in our clinical discussion about our case in pediatric and adolescent gynecology in the future. So thank you very much. It's very honor for us to have you here today. And on the behalf of our department, obstetric and gynecology department, we say very, very thank you for your valuable lecture in pediatric and adolescent gynecology. Okay, thank you very much, Professor Sonia Grover. Nice to meet you. Hopefully we can meet again in the future.
Thank you, and it's been my pleasure to talk to you all. Thank you.
Okay, bye, Professor Sonia. Thank you very much. Bye. Yeah. Dr. Ratri mungkin bisa menutup acara ini.
Thank you very much for the fruitful and interesting session. Dear honorable speakers, Professor Sonia Grovers and moderator Dr. Sinta. Finally, we are at the end of this event. Let us close this event by asking the speakers and the participants to take a picture so that we can remember this delightful meeting.
Okay, sorry, I said to Sonia before we should actually have picture together. Okay, next time we will do that. Okay,
Right.
because we still have meet with Dr. Sonia. Okay, we can have picture ourselves then. Oke, nggak apa-apa Ratri, kita mungkin ini bisa foto bersama dengan peserta aja.
Okay. The organizer will help us, and then in 1, 2, and 3. Thank you. We, as the organizer, would like to express our sincere gratitude to the speaker and participant who are joining this event. And we apologize for any imperfection, both the intended one or not. I hope this event will be beneficial for all of us. See you again in other events. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much all.